Okay, right. Hello, everyone. Welcome to our webinar on how hand therapy can help to manage your arthritis. I am Martin Lau, Dietitian and Services Development Manager for Arthritis Action. Today, I am honored to be joined by Sarah Mee, Consultant Hand Therapist at Chelsea and Westminster Regional Hand and Wrist Unit. Sarah has over 30 years of experience in hand therapy and will be sharing her insights on how a hand therapist can be of help to you. Hello and welcome to the webinar, Sarah.
Thank you very much. It's great to be here. Lovely to have so many people on the call as well. Welcome to everybody from London.
Excellent. Well, thank you so much for coming along. Now, before we get into the main content of today's topics, is it possible to share with our audience a little bit more about you, please?
Yeah, absolutely. So I originally trained as an occupational therapist and worked for 3 years in general practice and then started working in a burns unit and hand unit. I've now specialised in hand therapy specifically for 30 years. And I also do a lot of teaching. So I have my own teaching business, mainly teaching postgraduate for therapists, doctors, master's courses. I do lots internationally, lots of nationally as well. So it's a great opportunity to travel around. I do quite a lot of volunteer work in Malawi, particularly in Africa. So again, being able to get out there, and one of the huge advantages of COVID, if there can be an advantage at all, is the amount of virtual training that we've been able to do for people all over the world and within the UK. So I'm a consultant hand therapist. There are 4 of us in the country, and I run my own clinics direct from GPs. So I will see people, do all the imaging. I can book for surgery, I can organise injections. So I'm at a level of therapy that allows me to diagnose and treat in a slightly different way. I have a team of 16 hand therapists, half physio, half OT, and I work in a big regional hand unit in London. So probably half, maybe 70% of my practice is hand trauma from accidents, and the rest will be arthritis and other acquired conditions.
Wow, it's only 4 of you in the country. You're like gold dust.
That's a long time.
That's fantastic. Thank you. And thanks to those who have submitted questions beforehand. We will be responding to them at the end of the webinar. Before we begin, I would like to remind you that this webinar is not intended to be a substitute for medical advice. Always seek the guidance from your doctor or other qualified healthcare professionals with any questions that you may have regarding your medical condition. With the introductions and the disclaimer out of the way, I will proceed with today's webinar. Sarah, my first question to you is hand therapy a specialization for occupational therapy or OTs?
Yes, it is. You can specialise in hand therapy either from an occupational therapy degree or from a physiotherapy degree. Most therapists, once they've done their initial degree, will gain extra knowledge and become specialist in the field of hand therapy by treating hand and wrist conditions, working in hand units or working in specialist units, gaining experience from their senior colleagues. Hand therapists, it's a generic qualification now where you need skills that are both occupational therapy and physiotherapy, so that we can treat all aspects of hand problems, which again makes it very interesting for us because we're involved very holistically with every aspect of that patient. Rather than just one aspect. Occupational therapy is much more functional based. Physio is more movement, exercise, quality of movement based. But as a hand therapist, we do all of it. You can also gain an accredited hand therapist qualification from the British Association of Hand Therapy, which has been around now for maybe 15 years. It takes at least 5 years to gain the qualification, and you need to do a number of taught courses, a research project, and a minimum of 4,000 hours working in hand therapy. So if you've got an accredited hand therapist BART qualification, then everyone knows that you are at a good level of specialization. So in a hand unit, like I work at Chelsea and Westminster in London, I have a team of 16 therapists, all at different levels. So I probably have 5 or 6 who are not yet very specialist, but are learning and gaining experience. And then the other 10 of us are accredited, have worked for more than 20 years within hand therapy. And the last aspect, I think, is just to say that all of our surgeons, again, are hand surgeons. So they've also specialized either from plastics or orthopedics in hand surgery. So as a unit, we're all very specialist.
Oh wow, so complex. I guess that somebody that newly qualified really need to have as much patient contact hours as much as possible.
Yeah, no, absolutely. And I think, and we run because it's very specialist and it involves core skills from both OT and physio, we do an induction program. So they do 3 weeks just purely of training with a senior therapist before they start treating. And we, follow them very carefully for 9 months, 12 months to gain some experience before they carry their own caseload. So you have to do quite a lot of extra training to be able to work well in a specialist area of hand therapy.
Yeah. Okay. Now, because I know that you do see, a proportion of people with hand arthritis, could you give a brief explanation of hand osteoarthritis and rheumatoid arthritis, and a little bit of the differences, please?
Yeah, sure. So osteoarthritis we certainly see much more commonly. And this is really wear and repair of our joints. It comes with age. It happens to all of us at different times. It seems to relate very much to a combination of genetics, individual anatomy, and then what we've done with our bodies and with our hands. People who've done a lot of running sports are more likely to get it in their lower limbs, in their knees and their hips. But it's very much a combination of all of those aspects. You can do a lot with your hands, do a lot of heavy manual work with your hands, and it doesn't mean you'll get arthritis. So it's a combination of all of those. I think, as we say, it can affect any joint in the body, but in relation to the hands, the most commonly affected joints are the tips of the fingers or the tip of the thumb. And then the bottom of the thumb near the wrist. So they're the joints that will most commonly become affected. And again, they're the ones that take a lot of force. They're the ones that we squeeze hard with. When you make a strong pinch, if you're squeezing 1 kilogram at this level, you're pressing 12 kilograms of pressure through the base of your thumb. So over time, what happens is that the cartilage, which is the cushion lying between the bones, to give them that shock absorption, becomes thinner. It gets worn down. The ligaments that hold the joints nice and closely together stretch out a bit because the joint gets pushed around a little bit more. And the joint edges and the bones become rubbed down and can develop nodules and thickening around the bones. The joints can be painful at any stage. So sometimes they're painful even when there's nothing to show on X-ray and there's nothing to show that the bones have been affected yet. Sometimes it's not painful until later stages. And in many situations, further down the line, when joints become a bit stiffer, the pain is less because there's less movement and less grinding or catching of the joints as we move. So pain is quite variable for different people at different stages. I think with osteoarthritis, the pain is mostly worse during or after activity. It's often a deep-seated ache in the joint that sort of hangs around, that often is a bit worse overnight if you've used your hands and done quite a lot during the day. And the joints, as we say, particularly the tip joints, can become quite thickened and quite stiff over time and nodular. So that's very much, I think, osteoarthritis. Rheumatoid arthritis is an inflammatory disease process. So it's not about wear and repair directly from function. There is a genetic base as well, but it's a disease process. So it's something that it's an autoimmune disease that we have within the body. And it initially affects soft tissues. It starts to stretch them out. It causes inflammation, which can damage the soft tissues. And then gradually can damage the joints and the bones as well. It can cause sort of erosions within the bones. But initially, it's often much more soft tissue based. It's characterized much more by heat, redness, inflammation, softer swelling around the joints. So it's a much more obvious inflammatory process than just pain. It's, again, most commonly the big knuckle joints in the hand are affected. The wrist is often affected, the middle joints, but actually the tip joints of the fingers and the thumb, and often the base of the thumb, are less affected. So the common joints are quite different between osteoarthritis and rheumatoid arthritis. You also, with rheumatoid arthritis, have early morning stiffness, so it can affect many joints. It can take time to get moving in the morning, often half an hour to an hour, and there's often a level of fatigue. So just generally, people will feel much more tired across the day. The good thing nowadays with rheumatoid arthritis is there's very effective medical treatment. So rheumatoid arthritis is something that needs medical management, as well as hand therapy, physiotherapy, etc. And there are a range now of drugs and injections that will manage the disease process. So the thing for me as a therapist over 30 years is we see far fewer of the deformities and the sort of major problems that people had with arthritis years ago, because the disease process is managed much better. So they're very effective for many people, but need to get into that system early on so that people are treated well. And we'll talk a little bit more about changes in RA as we go through.
That's good. Now, is it true that the pain in the fingers, now I'm talking within the realm of osteoarthritis, the pain in the fingers, would they subside after the formation of the actual nodules, also known as the Heberden nodules?
Yes, it's, as I said earlier, it's a bit variable, but on the whole they do. Heberden's nodes, which are thickenings really again around these tip joints, develop as the joints themselves are more damaged. So the cartilage is thinned down. They grow as just bony lumps, I guess, the nodes on the sides of the joint. And the reason really that the pain gets less is as the joints are stiffer, they move less, and so you have less pain. So the reduction in pain is much more to do with joint stiffness than the nodules themselves. The nodules are a sign that the joints are at a later stage of change. And yes, the pain is often by then much less. They look different. So the cosmetic look of the fingers, they're often a little bit angled to the side. They can be thickened. They can look quite different. But yes, often the pain by that stage is reduced.
Excellent. Really, really good to know that. And, it sounds as though that the hand therapist is in such a good position, to support and also manage somebody who has got hand arthritis. Could you tell me a little bit more about how you guys can help, please?
Yeah, absolutely. So I thought what would be easiest for everybody is actually just for me to share my screen and just show a few slides and a few videos, just so that everybody, you get a chance to see the sort of things that we're involved with. So obviously the first thing is advice. And, when someone's diagnosed, often people come to my clinic for the first diagnosis of arthritis, or you may see your GP and they will be the first person to tell you, but you often don't get a lot of of education and advice really on and sensible advice, I think, on arthritis. It's easy to look on Dr. Google, as we all know, and get a lot of information that, people do blogs or information that may well not relate to you as an individual. They may well be more scaremongering. They may show the worst case scenario, which most people will never reach. So I think our first port of call very much is to give advice. The key thing with arthritis for everybody is to enable people to live as normal a life as they possibly can. Keep doing the things they want to do, not to reduce. We're not stopping people doing things. We're just adapting to allow people to do things in slightly different ways. So we do a lot of advice. There's obviously a lot of talk about pain management, which is very variable for different people. So we're able to give a whole range of different ideas that may, the GPs or the doctors will be more relating to painkillers. A lot of people don't want to use painkillers, want to try different methods that aren't so medical. So we have, again, lots of ideas to try for different people. We do talk and recommend sometimes trying topical creams such as Voltarol gel or ibuprofen gel, Tiger Balm, Deep Heat, Biofix. There are many things out there. And again, topical gels very much help more pain that's nearer the surface. They don't get deep into the joint. But for many people, even just massaging the cream in is comfortable. And I think it's absolutely something for people to try. And we very much say to people that it's about trying a whole range of different things, discarding the things that don't seem to work for you, but actually finding the things that are very useful. And I think that's the important. There's no one thing that will help everybody. And then diet, again, it's a very similar, say that the most of the information really relates to reducing very acidic foods. So again, eating everything, a bit of everything, healthy diet, but not necessarily having a lot of acidic foods every day. A lot of raw tomatoes can sometimes irritate. Red wine can irritate. Curry can irritate. Conversely, there's a lot now said about taking turmeric or sprinkling turmeric, having turmeric smoothies can be very helpful for joint pain. So I think with diet and pain, it's about trying different things. It's about staying healthy. And again, we have lots of ideas to try and help people to work through that process. And I see very much the job of the hand therapist as giving everybody an opportunity for a toolbox of options. So we'll start with different splints, different exercises, different ideas. We always expect to discard some of them because they won't work for that individual and try other things. It may be that somebody only needs to wear a splint once a month. It may be that somebody needs to wear a splint every day for certain activities. So it's about trying things out and for people to have this toolbox to be able to run their own lives and to be able to self-manage a lot so that it doesn't need a lot of time seeing a therapist on a regular basis. It's about learning how to manage our own lives within that. Joint protection we'll mention a little bit later. It's a hugely important part of just keeping our joints in good condition. If you have a particular grip, so one of the worst grips is the one we use when we're turning a key in a door. If you've got osteoarthritis at the base of your thumb, if you're using that grip every day with pain, you are thinning the cartilage, you are increasing the wear on that joint, and you're not allowing time for the cartilage and the tissues to try to repair itself. So there's a lot of information about just adapting grips, and you'll see the pictures I've put here on the slide are the O-type grip, or using all 5 fingers in a slightly sort of O shape. And they're the grips that keep all the muscles working well. They load all the joints and they reduce the loading, particularly on the tips and at the base of the thumb. So we're there to help people to learn to adapt grips. Again, do all your activities, but do it in a slightly different way. Martin again has mentioned that Arthritis Action has some fact sheets and are going to potentially be developing more of those. The other website that's very useful is now called Versus Arthritis, and they have a whole series of very sensible, common sense leaflets on looking after your joints, managing arthritis, gardening, diet, managing pain, post-surgery, so a whole range. And I think it's well worth finding those, looking at them. You can just go on to just Google Versus Arthritis and you'll be able to access them. We're also able to give advice on managing fatigue, balancing rest and activity, looking at things like don't do all your housework in one day, do one room a day, hoover one room and then go and sit and have a coffee, sit in the sunshine. So just again, small ways to balance one's life to make it more comfortable. Steroid injections, some hand therapists will actually do the injecting. I tend to send my patients to have them done under ultrasound guidance because it gives me some information about the condition of the joint at the same time. Steroid injections are very useful for pain relief in a joint, particularly in osteoarthritis, but they're often relatively short-lived. So lots of people get pain relief for 6 months to a year. Some people find it lasts a few weeks, or a couple of months only. We would always suggest you have hand therapy and all the advice alongside steroids, because if you're not looking after your joints and exercising well, the steroid injection is just a pain reliever for a short period of time, but the pain will come back. But it's a very useful adjunct. It's a very useful add-on to the hand therapy and everything else at a point where the pain is quite consistent. GPs do it. Or you can access it through rheumatology, you can access it through a hand surgery service or a hand therapy service. So lots of options for that. And then obviously hand therapy is involved in post-operative rehabilitation, which I'll mention. The other sort of key aspects, I think, are splints. And for those of you that have tried splints, there are many, many, many online, on Amazon, in chemists. And one of the problems, I think, is that unless you have advice on which to choose and how to fit them well, they often don't work. And we see many people that come in to say, we've tried splints, actually they were useless. It's more about the fit, and it's more about getting one that works. So splints protect joints in function. So if you are using your hands in stronger grips, a splint can just be a little like a hug. It can just be something that helps to support the joint. It can rest joints at night. It can be specifically for pain. The big thing with splinting is not to wear them all the time. The more you wear them, it allows the muscles and the joints to rest and relax, but it allows the muscles to weaken a bit. So balancing splinting with an exercise regime is the best. There are some very good gloves, either for compression. So these ones are Lycra gloves that can either have the tips out. They're really just for gentle, like a hug. They will give your hands a hug and make you feel a bit better. There are neoprene ones and the arthritis gloves that are very helpful in the cold weather. So a lot of people with joint pain from arthritis will be intolerant to cold. So they allow you to move, they allow you to function, but they keep your hands warm and compressive. So again, we provide those within the hand therapy departments, or they're available online. And then exercises, which we'll have a look at. Very, very important to keep the muscles strong while the joints are flexible. So the muscles hold around the joints and they stabilize the joints. So weak muscles mean that the joints move around more. So they're not as stable, they grind around a bit more, and you're more likely to develop and increase the arthritis problems that you have. So very important to have a program. We'll come on to the Isara exercise ideas a bit later. Really important to do them in pain level and short, regular periods of time so that you're not overdoing it and not pushing into pain. Splinting particularly, I've just put in some ideas of some of the good ones. You can get off the shelf. This is a particularly good one for arthritis of the thumb. You can see there's an extra strap here that supports around the base. It's neoprene, which allows movement, increases warmth, provides good stability. In hand therapy, we make individual neoprene ones because obviously often they don't fit just off the shelf. So we can fabricate them in the department. You can buy ones with metal pieces inside that give more support, but obviously are less good for the muscles. So you have to balance exercise with that. We make Again, small plastic splints, you can buy very small splints that are very good for function. This is particularly good. It's called a push splint. But again, all of these ideally need to be fitted and discussed with your therapist, because if you don't wear the right one, you're not getting the support that's appropriate. And we make just for fingers. So again, it can be really useful to have a little neoprene tube for pain at the tip of your thumb, still allows you to function. Sometimes if you have a joint that's not quite in the right position, or you're developing a little bit of weakness in a particular joint, there are splints that allow movement to be normal. So to return a movement or a position of a joint to a more normal position and allow for better gripping. But as I say, the key thing is to wear them intermittently rather than all the time. So again, many ideas, but best done within hand therapy. Joint protection we mentioned. It may, the keys are use bigger or more joints, so you're not isolating particularly the tip joints. Use equipment, so you can see here that you can use a very good gripper to get tops off, but it's important the type of grip you use. You can use a knife that gets your hand into a much better position, so you reduce the forces. Just using 2 hands for something that's heavier is a really good idea. Having bigger handled scissors is a much safer way of using them than a small pair. It may be that you need to have, this is a splint that's been made for someone with rheumatoid arthritis and a lot of pain in the big joints. So wearing the splint with adaptive equipment may be appropriate. So we talked a little bit about balancing activity and rest, looking at those versus arthritis and leaflets and the fact sheets. And again, this is something that we work through with people as part of our hand therapy regimes, but very much for people learning how to manage it themselves. I thought I'd put in most of stability exercises. These are getting those core muscles. These are getting the muscles that are hugging the joints to work better. It's a bit like Pilates for anyone who's done Pilates. It's not like going to the gym. It's not about straining the joints. And I just had a couple of videos. You can see this is showing a tiny movement of the thumb on the cone. The cone positions the span of the thumb in a good position. It allows these particular muscles in the thumb, which are the most important for supporting the thumb. You can see work through a bigger range of motion. So once you've got that early stability, but we're working on these particular muscles that are firing and supporting the joints. One of the really nice ways to get the finger and thumb muscles to work small is to put numbers on a ping pong ball and just spin the ball from numbers 1, 2, 3, 4, 5, 6. And as you spin, you can see how much all of these little muscles around the hand, the wrist muscles are working here, and you're getting all of that stability, again, working without pressure. You can sit and do it in front of the television. You can sit and do it when you're having a coffee. So things like that, again, are just giving you the ideas, the simple ways of doing something for 30 seconds every day that doesn't impact on your having fun and living your life as normal. A particularly good exercise for rheumatoid arthritis is crab walking. So walking your fingers towards your thumb like a crab gets the right muscles to work and stops the swinging over. So sometimes with rheumatoid arthritis, the fingers can end up swinging towards the little finger side. So just a simple group of exercises. Again, as Martin said at the beginning, these are ideas we would do once we've assessed somebody. So, you can see these, none of these will harm you to try, but don't do exercises really until you've been assessed. Don't take exercises off Dr. Google because they may be damaging for you and not work well for your joints. And just to mention postoperative, obviously, it may be for some people that you do end up with having had hand therapy, steroid injections. Hopefully they keep everything going for many years, but it is sometimes necessary for surgery for osteoarthritis or rheumatoid arthritis. It may be just improving pain. It may be, as with this person, replacing the joints, so putting artificial joints in to allow better movement. We would see people initially for splints. You can see here the dressing still in place for splinting and exercises. Somebody may just have had a single joint replaced, a single little finger joint replaced. We're doing specific exercise regimes. We're making splints like this that allow people to return to function after surgery, but in a good way, so protecting the surgery. Retraining grips, so the old grips that cause damage, we need to stop people using those, and we need to use the good grips that are going to keep the surgery and keep everything working well. So we see people after surgery often for 3 to 6 months, every week to start with, and then it's quite an intensive program for a period of time. But the majority of people that have arthritis will not need to go on to surgery, particularly if they have early hand therapy and early management, and live your life sensibly from there. So that hopefully gives you, a feel for, how we're working as hand therapists.
Wow, there's so many aspects that comes into it, which is really amazing. Now, you mentioned something called Sarah, or my Sarah, and then there's something that I've heard of. During the lockdown, I have an opportunity to do the online training for Isara, and I find it really helpful, for patients. But I have to declare, by no means that I can do hand therapy, because I don't even have that contact hours.
Yeah.
So Sarah, could you tell the audience, what it is, please?
Yes. So the Sarah program, it's got nothing to do with me, despite the fact obviously it has a great name. But the Sarah is a specific program of strengthening and stretching for rheumatoid arthritis. Now, it's not to say that it's not useful for osteoarthritis, but it was set up very much for rheumatoid arthritis. And it was set up by a group of therapists with patients. So they had a good cohort of patients with rheumatoid arthritis to help develop the program, and researchers in Oxford. And so it's been looked at very much for sort of evidence of what helps joints, what's safe for joints, what works well within the problems that patients with rheumatoid arthritis have. And it can be accessed via therapy. So you can train, as Martin, you can do the course and everything else. And you can either then access it face-to-face. So the Isara is for therapists to be able to work face-to-face with patients. So people would come in for 6 sessions face-to-face over a 12-week period. So you do a session, you have a couple of weeks to work on the exercises, come back, see how things are going, modify exercises and change things as needed. And that's the way it was set up until COVID. There's now a new system they've added called My Sarah, which is something that patients can access, or people can access, and work their own way through the program. But they still have to be given the link by a therapist, because the most important thing is that everybody has a chance to be assessed by a therapist to work out that it is an appropriate program. There will be some people who have particular problems with their joints, or at a particular stage of inflammation where it would not be sensible to do the program. So it's not something you can directly access online. You just need to go through a therapist and they can work it from there. It's a program of exercises and stretches that work on keeping the muscles stronger. It's done in short periods every day in order to not damage the soft tissues or overstretch the joints. You keep a tracker for pain and a tracker of the exercises that are done. And when you then come in and see the therapist or discuss with the therapist, pain is a marker. So if pain is increased, then the exercises are immediately modified so that it's not something that can damage. So, pain is very much seen as a problem when you're doing exercises. So you do basic mobility exercises and resistance exercises with a ball, with TheraBand elastic, adding gentle sort of resistance. So I'll show you a couple of videos briefly in a moment, but as I say, you need to go to an NHS therapist in the first place. They will then work out whether you do this face-to-face or online. And then you continue, if you do it online, you communicate with your therapist as you do it, so that there is still a level of sort of help on the way through. So it's a really good program. It doesn't suit everybody. And I do give it to some of my patients with osteoarthritis where it's relevant. But it's particularly, as I say, for RA. So I'll share my screen again. And I thought I'd just briefly show you. So you'll see there are lots of videos here, exercise diary and a guide. I'll just show you a couple of minutes. I hope you'll be able to hear.
So would you like to just try that now?
Maybe I'll just talk you through it, actually, because I'm not sure you'll be able to hear well enough. So this is sitting with a therapist. He's showing the exercise first, checking with the patient, going through the range of motion that works for that person, looking at, and then just correcting, so that making sure that the fingers are in the right position, that it's not producing pain, that it's done with a few seconds of hold, checking the wrist position doesn't change, so that at every point it's a learning system. If you do it incorrectly, or the quality of your exercises isn't so good, that's a problem. You get a leaflet that the therapist there is showing, so you have that leaflet either online or you're physically given it, so you've got a prompt. So when you're at home, if you can't quite remember, which we completely understand, you can then work back to your leaflet and work through it. And you're then given your home program. So once you've been through with the therapist, they will pick the exercises that work best for you. And the majority of those are about mobility. So that's keeping the joints nice and flexible. There's then another, sorry, let me just play this. There's another, this is now the resistance. Let me just turn that down as well. So what he's now doing is testing different squishy balls. And there's a chart so that you do 2 or 3 movements to squeeze. And on the chart, you say whether it's easy, it's moderate, or it's very difficult. And if when you're doing it, it feels very hard, it's uncomfortable, it feels like your muscles are really working hard, then that's not the appropriate level for you to start. And so you start with a lighter ball. So again, it's a very controlled program that means you are not at any point straining the joints or overworking things. And you'll see, we won't go through all of them, but you can see here are pots of putty, which again, a bit like Play-Doh. But you can use flour and water dough. You know, if you make bread dough or pizza dough, you can use that as well as putty. And then elastic band, again, at different sort of levels. So that's really just to sort of give you a feel for the program itself. And it's very useful. I think it's a huge difference that you can now do it online. It doesn't mean you need to go to the hospital for 6 different sessions. You can actually do it all online. And we're now running, I think everybody will continue to run some virtual treatment sessions. So when face-to-face treatment's not needed, then we can just do a quick 10-15 minute follow-up virtually to make sure that people are following the program appropriately. So I think it's great. I think it's a really good way, but as I say, you have to access your hand therapist first, or therapist. It doesn't have to be a rheumatology occupational therapist, a physiotherapist working in rheumatology, a physiotherapist working with a GP. Any of those will be able to access the Isara program.
Excellent, excellent. Really, really good to know that. Now, I know that you have been involved in a virtual group exercise for thumb arthritis over at your hospital. You know, I know that a program like this may not be available in other hospitals, but could you just briefly give us more information about this, please?
Yeah, absolutely. So many hospitals already run group education classes. And it's been something that, you know, we've done for 30 years. Again, it may be done via rheumatology OT rather than necessarily a hand therapist, but either for people with osteoarthritis or rheumatoid arthritis. And it was really a way of giving education on how to, you know, what's happening in the joints, what the future might hold, what symptoms you might expect, different options for treatment. And one of those was particularly exercise. So you could see with some of the stability exercises that I showed you, they have to be taught and managed quite carefully, like doing a yoga or a Pilates program. So we'll do those within that, as well as provide some simple splinting if need be. During COVID, so I guess the other aspect and the area that's maybe been lost in the virtual group was it was an opportunity for people to meet together. So, you know, to meet people with similar problems, to be able to just talk about what solutions do they have to challenges in function. And I think sometimes that opportunity to talk to people with a similar problem, you know, is really good. It's good to see people maybe who are worse off than you, or have more pain. It, you know, helps to put some things in perspective sometimes. So I think that's been a great opportunity. But what we've done in COVID is we now have a virtual education group. So we run group sessions where people have the same education, they're shown and taught how to do the exercises. Some of the simple splints or gloves can be sent out, so we just need a measurement of, you know, the width around the big knuckles or the wrist around the width. And then more often than not, people will still come in for a face-to-face appointment with a hand therapist, because it's often not enough. But it's been a really good way for people that obviously have been shielding, people who are older, who've not been wanting to come in. And I think it's something that will certainly continue. I think there will be quite a lot of other hospitals around the country that are also doing virtual groups. Obviously, there are a number of people who, not anyone who's joined this call, but there are people who don't have access to computers or Zoom calls, and obviously it's not going to work for them. But it's just another way. I think COVID has forced us all into managing some of these treatment options differently, and I think we'll continue to do that. So again, mostly you will still see a therapist for assessment and management, but it does allow for those early stages to be done online.
Sure, sure. Now, I know that you have mentioned it before. I have seen a few people they have already asked, you know, from a live chat box. So how could somebody with arthritis in the hand get to see a hand therapist?
So at the moment, the vast majority of NHS units won't allow you to self-refer. It's just the way the money works. It's the way the NHS works. So you can't ring or come into a hand therapy unit to be seen. What you need to do, your best port of call, is go to your GP. So see your GP. First of all, they do an initial assessment. If they need to do x-rays or blood tests, if they feel that it might be rheumatoid arthritis, or send you for x-rays, they can do all of that straight off. And that's very useful to have done all of those things in the first instance before you access anyone in the hospital. If there's an inflammatory component, so the joints are red, hot, swelling, you know, much worse after exercise, then it might be rheumatoid arthritis. There are obviously other sorts of arthritis, psoriatic arthritis, etc. So if the GP thinks that it might be more inflammatory, they would refer you probably first to a rheumatology service at your local district hospital. And within that rheumatology service, the doctors there will first of all look at the medical management. So they do all the different blood tests, they'll follow up with any other scans, and they will start treatment if need be from a medical point of view. Some units will have occupational therapists, physiotherapists working within the unit, and that may be the first port of call. At my unit, all hand patients referred through the rheumatology service will automatically be referred by them to us. So the rheumatology service can refer into hand therapy. We obviously don't then manage shoulders or knees or backs or anything else. You would go to a different therapy service if you had those problems. The GP may refer directly into therapy. As I say, they will often nowadays refer to primary care therapists. So those are therapists that are working within the GP community. And they will tend to be physiotherapists, generalized. They will not be specialist in hand therapy, but they may well, and they often do give very good advice. They may be able to give some basic exercises. But they are generalized. And I think what all of you need to remember is that it's fine to go through that route to start with, particularly if you have shoulder pain, neck pain, other problems, then that's a very relevant service to go to. But you need to request generally from your GP to be referred to a specialist hand therapy service. They don't tend to do it directly. They will try and do things in the community because it's cheaper. And most hand units are run at district general hospitals. We were talking to Martin earlier, and it's very variable around the country. So obviously in the big cities, in London, we have really quite a few hand units. We have 6 big hand units that will have more than 10 hand therapists in each of those units. Most cities will have at least one. It may be that if you're out of the bigger cities or not in a city, you may have to travel to a hand therapy service. But again, you're within your rights within the NHS to ask to be sent to a specialist unit that may be out of your area. If your area doesn't have one, you are able to ask to come to us. So you can Google hand units, hand and wrist units, check with your GP. They should know, and they can refer directly into that. Some units like ours, if you have a specialist service, a consultant hand therapist or an extended scope hand therapist, we have therapy delivered hand clinics. So in we cover the whole of West and South London, can be referred directly into my clinic. So you don't see a doctor at all in the early stages because you're not going to go straight for surgery. And as I said, I will organise scans, x-rays, bloods, injections. I can plan and discuss surgery. I can manage the steroid injections and obviously refer on for more involved hand therapy. So some units, as I say, you don't access a doctor at all. You will just come straight to hand therapy. And that's a really good place to start. So I think make sure that you ask the GP, if they don't offer it, that you want to see a hand therapist rather than a generalized physio. The other thing for some people is there are increasing numbers of private hand units. So the big the big private hospitals and the ones run by BMI, HCA, will have quite a lot of those will have hand therapists working directly within them. So if you have the insurance or the ability to go privately, it may be that you can access very good hand therapy services that way as well if you don't have any in your local area as well. So I think those are all, but as I say, just ask because it won't necessarily be offered.
Thank you so much, Sarah. Wow, I mean, I'm now looking at my clock over here. I'm quite conscious of the time, but nevertheless, this is really informative and I've learned a lot. I hope the audience feels the same too. Now, I have a few questions sent in by our members. And I also seen, a few questions popped up in my box as well. So if we cannot answer your questions, we will definitely try to get back to you via email. So the first question that I have is, are there any specific exercises that can help with pain in the knuckle joint?
So yes, I mean, again, with the knuckle joint, I'm not sure whether that is this. I presume it's the big knuckle here. But really for all the joints, there are, as you saw just from the few that I showed and also from the Isara program, there are particular exercises that will help. I think you always need to do exercises, some that relate to flexibility, and they may be just as simple as working through into a gentle claw shape, working into what we call tabletop, where you're working mainly these bottom big knuckles, coming down into a slightly flat fist and then into a curled fist. That's really basic mobility and flexibility. We don't tend to push them. We don't recommend that you force them because that's likely to take the joints beyond where they're comfortable. When we think about adding a little bit of extra strengthening for the knuckle joints, again, there are different ways, just in and out with the fingers. You can put an elastic band and do some gentle stretching. You can roll the ping pong ball. So it's about strengthening the muscles in a safe way. So as I say, thinking about it like a Pilates or yoga rather than a gym session. But again, I think for an individual, the hand therapist will direct your treatment depending on your range of motion and pain.
Be able to tailor to their needs.
Absolutely.
The second questions, I don't know whether it is beyond the scope of this webinar. It's related to ulnar, the ulnar nerve. It's now have to be moved to the other side of the elbow. Obviously, this member asked about how do I access hand therapy, which you have already outlined. It also mentioned that the right hand is quite weak now, and using computer and writing plus cooking is now being really difficult. I mean, is it something that, again, going back to looking at how the nerves are being affected, and then maybe just looking at more sort of like a strengthening program?
Yeah, I mean, nerve problems are really outside the scope of arthritis. With arthritis, there's no reason to think that you would end up with any nerve problems. You can certainly have nerve compression without any arthritis at all. Particularly if you have a nerve where it comes around your elbow here, where we talk about the funny bone, and the ulnar nerve comes around the elbow at that level. That's very rarely relating to arthritis. But obviously your nerve gives the electricity to the muscles. So it gives our feeling, but it gives the electricity to the muscles to make them work. And if you get a bit of compression or irritation of the muscle, then it switches off a bit of that electricity like a dimmer switch. And then, of course, you get slightly weaker muscles. They don't work as effectively. So certainly keeping the flexibility in all the joints is really important. Doing strengthening is particularly important. And depending on which nerve is irritated will be a different set of exercises. So the ulnar nerve sends electricity to the little muscles around the hand, particularly, whereas if you have carpal tunnel syndrome, where you have the nerve compressed at the wrist level, that involves the thumb much more. The ulnar nerve involves mainly the little finger and the rest of the hand. So the type of exercises will again be tailored by a therapist, but it's important to ask your GP to come to a hand therapist, and the exercises and management can be tailored.
Thank you. Next question, what is your opinion regarding steroid injections in the hands?
So I mentioned that briefly. I think they can be very effective. There are very few side effects. They're not a steroid. We talk about taking steroids if you take them as tablets, and there being lots of side effects of putting on lots of weight and all sorts of different side effects. A steroid injection is very much located into the joint that is painful, the tissues that are painful. So there's very little risk. Very occasionally you can get a change in the pigment in skin around it. You can lose a few little fat cells around it and have a little divot in the skin. But if it's done by somebody who's experienced, there's very little risk to it. And I think it's a very good adjunct. I guess, I'm a hand therapist. I would always suggest hand therapy as the first port of call. If I see somebody who is already a bit down the line and has quite a lot of pain, aching pain most of the day, consistent pain that's worse after activity and lingers for hours afterwards. Those are the situations where I think steroid injections can be very useful. So again, alongside hand therapy, because steroids are just there as they're an anti-inflammatory. So you tend to have that deep-seated aching pain because the joint is irritated, because it's being pushed around in a way that makes it uncomfortable. So a steroid injection then is a very good idea. But as I say, it's variable. So it may work really well for 6 months to a year. It doesn't mean that you'll have no pain. Its biggest benefit is to reduce that constant low-grade achy pain. If you get pain when you're opening a jar and you get a sudden sharp pain, it doesn't stop that, because that sudden sharp pain is mechanically where the bone is hitting on the next bone, and it's not able to do that. So it's a very good adjunct. But as I say, I think it's best done alongside a program of exercises as well. And the last thing I think just to say with them is that you need to leave at least 6 months to a year between. So it's best to leave a good gap to allow the tissues to settle and recover a little bit before you put more steroid in. So it's not something we do often. Every year or so is fine.
Really useful to know that. Now, the next question, are there any specific exercises that can help with the middle finger, middle finger pain, as I find the pain goes up onto the hand to the wrist, rather like a nerve pain?
Yeah, and I think, again, as we've mentioned, I think it's about how the exercises are done. So depending if we're talking about the sort of middle knuckles, keep the flexibility, but don't force it. So it's not to push it straight, or, the more you force the joints, the more uncomfortable it can be. If you hold a position for a period of time, it can irritate. If it feels like a nerve pain, so if it's a burning pain, like an electric shock pain, a tingly type pain, that may be a nerve pain, and that may be an irritation that can come from the nerves in the neck. People with osteoarthritis particularly will often have, gradually over time, a bit of arthritis in the neck, and that can irritate the nerves at that level, but you feel the nerve change and the nerve pain in the hand. So we see a lot of people that don't have a lot of neck pain, but actually that is where the nerve is being irritated. So with any joint, it's about keeping the flexibility. It's about working on a little bit of sensible resisted strengthening, but not to overdo it. And I think, as I say, I think if you're experiencing nerve pain that is particularly giving you electric shocks, tingling, pins and needles, numbness that lasts for a period of time, then that needs again to be assessed by somebody to see whether that is not only arthritis, but actually is a nerve problem as well.
Thank you. The last question. I get a lot of cramps in my hand when I use a knife, using a pen, etc. My hands pain a lot. Well, she experienced pain a lot when she picked things up. Her wrists are extremely painful when she, for example, holding the phone in her hands, and also become numb for no reason. Is there any things that she could do about that, please?
Yeah, I think what I would suggest very much is that you go and have a good assessment of everything. I think pain in the hands, it sounds like if you're getting numbness in both hands, and it can happen, randomly at different times, there can be numbness across the whole of the hand. You would want to have your neck and this more area up here looked at, because numbness over all of the hands and in both hands may well relate to things being irritated around the neck.
Yeah.
Cramping and pain in the hands, again, often relates to muscle weakness. So it's a bit like you're holding on to something for a period of time. If the muscles are weak, you're making them run a marathon when they're used to only being able to jog to the end of the road. So that brings us back to the importance of building those muscles up in a Pilates type way. So the better the muscles are from a stamina point of view. So it's not only about pure strength. It's about, can they do a grip? Can they hold, can you hold your coffee cup for long enough to walk out to the garden and sit down? You don't want it to start shaking. So that's about stamina, and that's about muscles. So cramping is more often to do with muscle strength than anything else. But I think very much for that particular person, asked to be seen in the rheumatology service, maybe initially just to look at all of you, and then they can refer on to a hand therapist for the more specific hand problems.
That's a really good way to put it. I think the conditioning side of things, people often completely or not aware that do plays a part. Right. Okay. Wow. It's 1:30. Time just absolutely flew by. Well, thank you so much, Sarah. Really appreciate it for giving up your precious time to come and chat with me. I know you've got an extremely busy caseload. Now, as much as I've been enjoying learning from Sarah, sadly, this is the end of our webinar. So thank you very much for watching. But before you go, if you would like more information relating to arthritis, please do not hesitate to visit our website, which is www.arthritisaction.org.uk. We have a lot of different resources that will help you self-manage your condition. And also, we have a dedicated webpage on COVID-19 advice and information, which is updated regularly to reflect the latest government guidelines and advice. Now, I know that a lot of you have asked. A video of this webinar will be made available shortly on our YouTube channel. We will send you an email and a link to the recording once it is done. Certainly when my comms colleagues have been nicely edited some bits and pieces. So all that is left for me is to say a big thank you to Sarah for your time and for answering our questions, and also thank you for everyone for watching and joining us. Stay safe, and we're looking forward to see you really soon. So take care and bye.
Bye. Thanks very much. Good to see you all. Bye.
Bye.